Good day everyone, we are the Group 6 and we are here to discuss about pediatric low vision management in case of myopic maculopathy by Devanshi M. Dalal and Davyat Shah. In this case study, a pediatric case of myopic maculopathy is described, to which we are going to talk more about later on. So for the abstract of the study, pediatric low vision management in case of progressive condition like myopic maculopathy should be an integrated approach of low vision aids and rehabilitation, including vocational training. So a little overview of the case, the pediatric patient's best corrected visual acuity was minus 13.50 combined with minus 1 axis 40 with vision of 624 in the right eye. While for the left eye, subjective acceptance was minus 12.75 combined with minus 50 axis 50 on 618. Now let's tackle what is myopia. As we all know, myopia has two classifications based on anatomical features, and that is axial and refractive. Axial, whereby the eye is too long for its refractive power, and refractive, whereby the refractive system is too strong for its axial length. So myopia that is pathological is often referred to as high, degenerative, and malignant myopia. So it describes a situation where a person has an axial length of greater than a typical cutoff, which is around 26 millimeter, and with a corresponding refractive error of at least minus 5 diopters. So myopic maculopathy is a pathological myopia. So of course, it has been accompanied with pathological changes, which are seen in atrophic changes, neovascular changes, and tractional changes. Now, myopic maculopathy is becoming one of the causes of irreversible blindness in certain regions of the world, and it is now the most important problem in East Asia. Now let's welcome Camille to discuss retinopathy of prematurity.
Besides myopic maculopathy, retinopathy of prematurity will also be mentioned in this case study. ROP is a proliferative vitreoretinopathy that affects premature infants. This is due to premature babies being exposed to too much oxygen during incubation, which will affect retinal development. Premature children, especially those with ROP, are more likely than full-term children to develop myopia later in life. It is said that as degrees of prematurity and ROP severity increases, myopia becomes more prevalent. According to estimates, there are 1.5 visually impaired children worldwide, 66% of whom are Asian and 0.25 million of them are Indian. In light with this, Devanshi M. Dalal, an assistant professor and clinical coordinator in optometry at Parul University in Gujarat, India, and Daivat Shah, the head of Vitreoretina Research and Academics Department at Choitram Netralaya Hospital in Madhya Pradesh, India, has conducted a case study of pediatric low vision management of a patient with myopic maculopathy.
So let's proceed to the case history of the patient. A 10-year-old male child was diagnosed with myopic maculopathy at the age of 3 months old. The chief complaint of the patient is increasing loss of vision in the last 6 months and difficulty in seeing in blackboards. He was diagnosed with myopia since the age of 1. They also revealed that stand-high myopia in his younger sibling and ROP is present at birth. And both of his parents was diagnosed also with myopia. So this is the summary of the findings. The subjective acceptance was minus 13.50 combined 1 axis 40 with a vision of 624 in the right eye of the patient, while in the left eye, subjective acceptance was minus 12.75 combined minus 0.50 axis 50, and he can achieve 618. And for the near vision, N10 at 40 cm and N6 at 15 cm with efforts. So in this table, positive finding were both eyes are central scotoma and Amsler-Gay test due to the macular defects causing central vision loss. And for gross visual field test, specifically the confrontation test, both eyes are normal. In ophthalmoscopy examination, posterior segment evaluation for both eyes are shown in the table. High myopic fundus with a disc of 0.5 CD, posterior cephaloma is present. Tessellated background, thus the diagnosis of myopic maculopathy was confirmed.
Moving on to the low vision management, optical correction of myopia using conventional spectacles usually improve visual acuity. The patient subjectively accepts minus 13.50 combined with minus 1 axis 40 on the right eye where he can attain the 624 line, and a minus 12.75 combined with minus 0.50 axis 50 for the 618 line. Based on the calculated magnification requirement for distance and year, a low vision aid trial was given. Since the patient had difficulty in seeing the blackboard, for distance magnification, a 3 times monocular handheld telescope thought for spotting, fixation, and tracking was used, and he can comfortably read the 6.6 line. For near, based from the calculated requirement, a times 1 magnification was needed. So the first trial was a +4 diopter near addition, but due to close working distance, the acuity stays the same. To keep the hands free for work, higher near addition was tried, and for the second trial with a +5 diopter near addition, the patient still shows no improvement. So, for prolonged reading, a 2 times dome magnifier was tried, and he can read comfortably the in-4 print. Other than the optical devices, non-optical devices best for the patient are: first is a reading stand. A reading stand for extended period of reading task. This allows to maintain a close working distance without straining the neck or tiring the arms. In addition, when at school, there must be proper illumination and the child is advised to sit on the first bench. He must be informed with the availability of large books or audiobooks. The patient must also understand the need to bring a flash along for difficulty in moving around in dim lit areas, as well as be informed to have vocational training at the nearest rehabilitation center. This case will be further discussed by Kathleen on the next part.
Retinopathy of prematurity is responsible for up to 15% of all causes of blindness in developed countries and up to 60% in middle-income countries. Myopia has also been demonstrated to significantly increase levels of anxiety among children and adolescents. Diaz et al. Reported that children who experience more visual symptoms, for example, tired eyes or headaches, tend to evaluate themselves less favorably in terms of physical appearance, schoolwork, social activities, and behavioral conduct. Studies from high-income countries have shown that adults with high myopia reported psychological, cosmetic, and financial factors specifically related to myopia that affected their quality of life. With increasing complications, the medical field is also had made advancement in managing those. Orthokeratology refers to the creation of specially designed rigid glass permeable contact lenses to reduce or eliminate refractive error temporarily by reshaping the corneal curvature. Ortho-K treatment may reduce the degree of myopia and its progression, especially in young children. It is effective, safe method, and reversible process. Also, giving low vision tools they need to practice self-advocacy will help them advance their independence and get beyond challenges they will inevitably face throughout their life.
As what discussed earlier about the struggles with living with the low vision condition, this condition could lead to dependence, decrease the quality of life, and sometimes depression. Early diagnosis and better management can save the child from being dependent. Vision rehabilitation treatments that educate children how to use their remaining vision more effectively can enhance their quality of life. For children with progressive ocular conditions leading to low vision, avoid shifting instantly to Braille and rehabilitation. Instead, provide them with low vision aids that may help in independent living and continuing education in the normal schools. Several visual and adaptive aids like spectacles, monocular handheld telescope, and dome magnifier can help people regain or maintain their independence. When possible, integrated education for visual impaired children is preferred, not on special education. Special education is a system of education that responds to the needs of children with disabilities outside mainstream education, while integrated education is provided within the general classroom where the special needs students learn alongside their peers without disabilities. Non-optical low vision aids always play a supportive role in management of low vision. In this case, apart from magnification devices, using of extra illuminations also enhance the contrast, thus increasing quality of vision in child. Recent studies suggest electronic magnifications are better in case of progressive disorders. It would work for both distance and near, as child had limited requirements. But if only for studying and higher magnification was not needed, then electronic magnifiers were not preferred.
For the conclusion, low vision aids such as monocular telescope, stand magnifiers, and dome magnifiers are helpful tools that makes a difference for prolonged reading among low vision patients. Non-optical low vision aids always play a significant role in management of low vision, such as extra illumination, large print books, audiobooks, etc. Through integrated education, both optical and non-optical low vision aids can help people regain or maintain their independence. Vision rehabilitation is as important among optical aids to educate them how to use their remaining vision effectively to enhance quality of life. Pediatric low vision management in case of progressive condition such as myopic maculopathy should be an integrated approach of low vision aids and rehabilitation including vocational training. And through it, we can make a difference one eye at a time, thus making the world become a place where we see each other eye to eye.